Hello, Dr. Alex Hsieh. Welcome to our time together. Thank you so much. My name is Dr. Ronald Asimwe. I am an assistant professor in the Couple and Family Therapy program here at the University of Minnesota. And today I'm hosting Dr. Alexandra Hsieh, or Alex, as he prefers to be called in this interview. Dr. Hsieh is an associate professor at Alliance International University in California, I believe. If I get that wrong, correct me. He is a clinical training coordinator and the past branch director. So, Alex, lovely to be here with you. Really, the purpose of our interview today is to really at the University of Minnesota, we're in the process of revamping our MFT training videos. We all remember when we went to graduate school, we had the master series videos. They were great in those days, right? But as trends continue to change and contemporary practice continues to change within the MFT field, we thought, well, why don't we also seek to capture voices of therapists that identify faces and voices of therapists that identify as BIPOC or diverse kind of therapists. And so we're privileged to have you today and thank you for honoring our invitation. So I have a series of questions that I'll be walking us through to kind of um, walk us through your journey of how you got here and what kind of theories you practice from or theory you practice from and how why you love that theory and then we'll talk a little bit about the dynamics of theory. So do you have any questions before I get started, Alex?
No, thank you so much, Dr. Msumwe, for this invitation. So I'm really excited to be able to provide this for the future generations of marriage and family therapists. Thank you.
Excellent. Well, Alex, let's jump right in. Tell us a little bit about your identity or and any parts of your social location that you are comfortable with sharing with our audience today.
Sure, sure. I'm a heterosexual, cisgender, Taiwanese American male. I'm in my late 30s, and I would say in the middle class SES, and in terms of geographic location, in a urban West Coast, Northern California location. So I think that kind of matters in terms of the intersection of the types of clients, geographic location of the clients that I work with.
Thank you, Alex. How did you choose the field of couple and family therapy, or MFT as we have known it over the years, over other mental health disciplines? What attracted you to MFT?
Yeah, yeah. So I think that's a kind of a funny start to kind of my journey here is I actually never knew anything about therapy, never knew anything about psychology. I went to college for biochemistry and pre-med. I was kind of from early on set to go to medicine, go into becoming a physician. And by my junior year in undergrad, realized that that was really not the field for me. So ended up kind of pivoting and majoring in human development and family sciences, kind of last minute in undergrad, and having no idea what to do with that degree, no idea what to do with that field. I graduated from college and consulted with a friend who just happened to be in a marriage and family therapy program. And honestly, going into that field, I kind of thought to myself, well, hey, relationships are important to me. My family is important to me, social relationships, intimate relationships, those have impacted my life in so many different ways. And so looked into therapy, looked into MFT. And at that point, just kind of thought to myself, okay, well, why not? Let's give it a shot and spent my 2 years at Abilene Christian University and really, really enjoyed what I was doing and decided to pursue academia as well. And so kind of a big pivot. I wouldn't say I knew exactly what I was doing at the beginning, um, but have just kind of fallen to that field and have enjoyed it ever since. Yeah.
Wow, that's an incredible story, really coming from the hardcore sciences and,
Mhm.
to your words, not knowing what you're really doing. And now here you are, very prominent and well-known MFT. I mean, what an incredible story. Thank you, Alex, for sharing that journey with us. So when you think about there's many models of family therapy that we all learn in graduate school, from Bewinian to structural to satire to experiential to strategic EFT. What model or models influences your practice? And
Yeah.
maybe if you could tie that to why do you practice according to this model?
Mhm. Sure, sure. I think very early on in my career, back when I was doing in my master's program, I was really drawn to structural family therapy. It just made sense. The concept of hierarchy, the concept of structures, roles, boundaries, really resonated with my Asian American culture. It was something that's, culturally speaking, it's what I grew up with. It's what I, more or less kind of adhere to in my family life and in my relationships, my relationship, my parents, extended family, etc. So it- early on in my career, early on in my education, that those theories, those understanding of therapy, the understanding of relationships through a structural family therapy lens really just kind of made sense. But as I began to do more therapy, what I realized within myself was the sense that structural family therapy was too rigid for me. Structural family therapy, there was kind of, I mean, there's kind of this paradox of boundaries. And essentially, like my therapy was essentially sometimes kind of pushing those boundaries a little bit. So I kind of as I began to learn more about internal family systems theory by Richard Shorts, that resonated with me not only from a professional perspective, but much from a personal perspective as well. The way that I thought, the way that that I perceived my relationships and kind of my surroundings come from a parts perspective, kind of this perspective of multiplicity. And I think that was just a natural way that I think. And I'm a firm believer of at some point in our therapeutic careers, there is a merging of not only our profession, but our personal way that we think and interact with others. And um, when I started to go into more IFS, there became more congruency of not only how I do therapy, but really how I live my life, how I perceive my life, how I perceive those around me, and how I interact with those around me as well. And then, as I developed more and kind of learning more about my theory and my understanding of how I practice, what was also at the core is attachment theory. Not necessarily EFT, but more of just the basic understanding of attachment theory. What I do therapy now is a blending and integration really of attachment theory and IFS. And I think those are two kind of theoretical lenses that link pretty well together. And kind of what is at the core is our self-to-self interactions between us and others around us. So that's kind of where I've developed myself and kind of where, at least for the past, I would say 15 years or so, how I've been practicing therapy.
Love that. I love how your journey is full of really experimenting and trying out different models, which I feel like is a trajectory we all come onto this path. When we were young, when I was a younger therapist, I felt like there was this push to like fit in a particular model
Mhm.
in my graduate training. And I like how you reflected on this that I had a supervisor who used to say, find out who you are and then find a model that speaks to who you are rather than trying to fit yourself in a model that doesn't really fit who you are. I love that you found that you use the words model that fits your natural way of being.
Mhm.
I love that. So right now IFS, an integration of IFS and attachment theory, correct? Did I get that right?
Correct, correct.
Yeah. Does my understanding is that IFS requires some specific training. Do you mind describing a little bit about what the training process for IFS looks like? That's
Yeah.
Intimate Family Systems.
Yeah. I think you can become a certified IFS therapist. I've done the level one training
Hmm.
for IFS. I'm not at that point to be called a certified IFS therapist. But I think the beauty about our fields a little bit is you don't have to be a certified IFS therapist in order to do IFS. And I think the majority of therapists who actually do IFS aren't, certified in a specific in that specific model and whatnot. It does help. It absolutely does. It does kind of help more theory fidelity. It does help hone your skills a little bit more. And I think part of that piece is the confidence level of you as a therapist. The more you get training, the more you maybe sometimes even get external validation of, oh yeah, you're doing IFS. You
Yes.
do grow in as a competent therapist. But I really like what you said earlier of like it's really finding yourself in the theory rather
Yes.
than trying to fit yourself in the eyes of what the theory is.
Mm,
Because I
mm.
think there's very much this congruency, and you have to be congruent to who you are as a therapist rather than being congruent in what the theory necessarily says. But
that. I
yeah.
love that. Wow. Pretty wise words. Love them. Um, so what kinds of clients do you typically work with, and what kinds of problems, so if you could tie clients and problems, do you typically see
Yeah,
in?
yeah. So I would say probably for the past 10 years, it's really been I work predominantly with pornography clients, clients who struggle with pornography. So I do that from a context of individuals, couples, and family systems. And the other group of clients I work with are Mandarin speaking clients. Really like my journey as a therapist has been about kind of what my local community has needed. And what I do have some training, I wouldn't say extensive training necessarily, but most of my training has been working with these two specific populations. And currently where I reside, there aren't a lot of therapists who speak Mandarin. And there are not a lot of therapists who look at pornography from a systemic perspective. And so, over the years, that's kind of what my community has needed. So that's kind of what I've been able to provide for the community.
Thank you, Alex. Well, every model of family therapy has a particular, or you know, a particular set of interventions, or an intervention could be one or two that they are known for. For example, if you talk about reframing, you're talking strategic originally. You talk about enactments, you're talking about structural originally, which is where you started. I also started as structural, by the way, I didn't share that. Then I kept transitioning. Can you describe a well-known intervention from your theoretical base that you from how you practice, a well-known intervention, and what is the purpose of this intervention?
Yeah, yeah. So I'll kind of set it with a line with the kind of the lens of working predominantly with clients struggling with pornography addiction.
Hmm.
I've been very, very successful in kind of using IFS, using the parts language, using the parts differentiation when working with clients struggling with pornography. And specifically um, working with the parts that's associated with shame,
Hmm.
especially shame and sexuality.
Hmm.
The interventions a lot of times I use with clients, I use those imaging techniques. I use having parts of our clients in a specific room, creating some boundary there between our parts, but also helping to facilitate compassion, curiosity, and connection with some of my clients' parts that are eliciting shame. And that has helped my clients become more empathetic of themselves and their struggle. A lot of times, our clients come to me with criticism. Sometimes that's external. Sometimes that's external. That's kind of bled into the internal as well. And so those imaging techniques really do help facilitate compassion, curiosity, and connection. And enactments are a very, very powerful intervention, not only with IFS, but other theories as well. And the purpose of that is to help experience parts interactions between family members and capturing kind of that here and now experience of what a part is expressing or feeling. And I've been able to successfully do that within a system perspective, just to express empathy and just to kind of, and sometimes, even activating a client's core self, individual core self. Enactments, I feel like, are just very, very powerful intervention tools to help take this perspective of partners, take the perspective of family members, and kind of create that connection between our clients and the systems that they reside
I love that. Thank
in.
you, Alex. Really beautiful work that you do with integrating the imaging technique within IFS into the language of parts. And as we speak here, I realize that I'm assuming for our audience that maybe they know what parts you're talking about. Could you help us describe briefly about the parts? I know that IFS has three parts, if I
Yeah,
remember, if my memory serves me correctly: exiles, firefighters, and managers.
yeah.
Could you tell us a little bit about what each of those parts kind of mean?
Yeah, yeah. So here's maybe where I deviate a little bit from shorts. Shorts in its purest forms, we do have those three parts, right? We have firefighters, exiles, and we have managers. I kind of tend to categorize them. I'm not saying like shorts. Shorts definitely does do this as well. I kind of categorize them to exiles and protectors,
Mm,
where we have, really firefighters and managers as protector parts, and then
mhm,
exiles obviously in the exile parts as well.
mhm,
Oftentimes the shame piece does become that exile.
mm,
Whereas the managers and the firefighter more from this kind of critical perspective, trying to protect sometimes the internal system and the external system from the exile, from the shame of what's going on internally as well. Shame sometimes it can be generational, it can be multi-generational, it could be trauma based. It could be an experience that some of our clients have.
mm.
It tends to get, in some ways kind of locked away and put away. And that's kind of where the doing of our protective parts. So when I'm talking about parts, that's I kind of categorize into, the exile and then the protectors. So
Love that, love that. Again, it ties back to the piece we were talking about earlier of making the model fit you, Alex, rather than doing it like the developer did it. I mean, we still remain within the realms of the fidelity to the model, but um, doing it the way we see it and envision it with the type of clients we work with. I love that you're able to make that adaptation
Mhm.
to fit your client population.
Yeah.
I'm curious, Alex, as we talk about imaging technique and parts within IFS, when do you not use a technique such as imaging? Is there a time like that anyway?
Yeah, yeah, no, absolutely. I think safety is key
Mm,
to working with my population of clients. And sometimes this could be safety within themselves, the criticism, the shaming that sometimes my clients exhibits individually. But I also think safety is a key factor when we're looking at systems. Oftentimes, I work with couples in terms of utilizing IFS and working individuals struggle with pornography. And safety is always a concern. Is what is the partner's role? Is there this sense of high criticisms, high shame, this is something that you did and it's unforgivable. So I gauge that. I think it's using that imaging technique. Again, the goal is to foster compassion, to foster empathy. But if the individual or the partner, if we're not able to draw that piece out yet, if we're not able to maybe even push back the criticism, the manager parts, the protector parts yet, then it's not safe to do that. Imaging wouldn't be safe yet. Imaging would actually cause more shame and cause more destruction within the relationship than it would to help.
Pretty profound that you have that awareness of when not to use this intervention
Mhm.
and when to use it. Um, Next, Alex, I would love you to walk us through, give us an example of a client that you've worked with using, for example, this imaging technique that's recent, obviously staying within the boundaries of confidentiality, so no naming, no mentioning names. How did it work out for your clients?
Yeah, yeah. So I think this is like a combination maybe of a few clients here, some commonalities and some of the things that I do. But I remember I had a client who I was working regularly engaging. The client was regularly engaging in pornography along with masturbation daily, but was also in a committed marital relationship. So although his partner knew about the pornography usage, the amount and type of pornography was unknown. There was almost this kind of understood, although it wasn't clearly articulated what the rules were, pornography usage was still there. The couple had a fairly routine and vanilla, I would say, sexual intimacy that very much lacked communication and was relatively repetitive from their perspective. And I think from that, the individual sought pornography to experience a different alternative sexual experience. And I think within that, he was taught growing up that was shameful. So you can see kind of how that exile piece has transformed through the years as we did family history, as we did relationship history on both of the individuals. He grew up more in a conservative culture where sexual intimacy was never talked about. And within the couple system, we worked on not only parts differentiation, teasing out sexual desire and intimacy with one another, with shame from their sexual acts and past childhood trauma. And I think imaging over the years of I worked with this couple for about 2 years or so, and the imaging technique really allowed my clients not only to foster compassion with himself, that this desire to want closeness through sexual desire and intimacy it was not shameful, is not deviant.
Mm,
And but he felt like it was, so he sought pornography. He sought, masturbation through pornography. And it was always hidden here. And actually, as the partner started to see this, started, using when we did some imaging techniques and even some enactments, um, the partner responded with compassion. The partner responded with, "This is something I don't know anything about, but I want to walk this journey with you. I want to grow in I don't want to say necessarily kinkier sex is necessary growth, but for them it was.
mm,
For them, it was kind of walking together in terms of sexual intimacy.
mm,
And actually, with that, the partner felt less abandoned because when the individual I was working with, who struggled with pornography, he was participating in pornography and masturbation. It felt like from the partner that he was on this journey alone. He was on this sexual journey alone and leaving her out.
mm,
And then actually when he started to talk more about some of the what did he look at in terms of pornography? What were some of these sexual acts that he looked for that he was deeply ashamed for? His partner said, well, why don't we do that? Why don't we engage in some of these things? Some things that they like together, and some things they're like, well, no, this is really not what we want. Pornography gives a really unrealistic perspective of sexuality and sex and sexual intimacy. And she came from a perspective of more reserved in terms of sexual intimacy and she didn't want to be perceived as sexually deviant as well. But in reality, she wasn't satisfied with sex either. And it was just something that they did routinely in a way that they felt like it was supposed to be done rather than exploring themselves, rather than exploring each other, rather than exploring how they can grow together as a couple. And then the imaging intervention really helped the couple express compassion and curiosity and eventually connectedness, confidence. I mean, these are all the AECs of our core self. And particularly courage with one another. The amount of vulnerability this couple was able to express took so much courage. Uh,
Mm,
and that can only come from our core self. Right. And I think over the time and work with them, and really kind of the work that they put in led to more connectedness, more confidence. And what they were able to do, I think most couples don't talk about sex.
mm,
But they talked before sex, they talked during sex, they talked after sex, about their level of connection, about their level of comfortability, about their, likes and dislikes. And that created a great amount of connection, because it was vulnerable.
yeah, wow, very powerful. It was vulnerable. The shame was taken away. More compassion was built through this amazing technique, imaging. Wow, Alex, thank you so much. I don't know if I could say anything more to that. It's pretty
And
powerful. Just
and
want
right
to
there,
confirm it.
Dr. Asimwe, you said like the shame was taken away, and because I mean, Brene Brown, very popular in working with shame. I mean, we shone a light on shame.
Yes.
Shame was not allowed to be in darkness anymore, and
Mm.
that was so powerful for both individuals there.
Mm, mm. I love that. Wow. Well, we're out of our time here, but I'm wondering as we finish really this amazing interview, really getting me also to think about just IFS at depth and its integration with attachment. Are there any contextual challenges you face in practicing according to this integration of IFS and attachment theory?
Yeah, yeah. I think trauma and trust is
Mm,
something that sometimes can be very, very difficult to navigate.
mm,
So that's something that you as a therapist have to be very, very cautious of and be aware of how much does your client trust you. And sometimes it could seem like your client trusts you, but is it a part of them or is it the part that you actually want to work with? Our client's manager part is really good at sometimes pretending and saying, okay, everything is good, everything's okay, I trust you as a therapist. But they are kind of just functioning within the role, a
mm,
little bit there. So that is something I always try to contextually want to be aware of because that can be a challenge, in working with my population,
mm.
and challenge for IFS as well. Yeah.
Wow. Love that. I love that. So how do you, I'm just curious as we wind up, how do you notice when there's a part of a client that's maybe trying to play within the role? Like how do you catch that and how do you address it?
Yeah. Usually I notice it when there's a resistance to change.
Mm,
There's a resistance to, it's like, oh, okay, oh, let me try that. Let me try doing that. And then next week they come back, and say, oh no, I didn't do it. And
mm,
that kind of continuous sort of work. There's a discontinuance in the work that they do outside of therapy. typically is my first flag of, okay, am I really engaging with the part that I need to, or is this really a protector part that's over functioning for another?
Mm. Wow. I love that level of attunement. Um, Final words. I ask this all the people that come on this channel through these interviews with me. Do you have any words of advice for people that are interested in the MFT field, specifically those that are interested in either IFS or attachment theory or an integration of both? Any
Yeah.
words of wisdom?
Yeah, yeah. In terms of like kind of the greater mental health field, I think if I were to speak predominantly with my MFTers, I would say systemic theory is what we're all about, and we have to be attuned to that. We're not, we don't do therapy with individuals within a family context, within a relationship context. I would say we don't even do relational therapy. We do systemic therapy. And I think that is very different to what any other field does. And we need to practice that and do that authentically. And another thing about our field, I would say, like especially as more and more go into the private practice model, which is not a bad thing, but I think there's this notion of we function in an island.
Mm,
And we're in private practice and we see our clients, and that's kind of all we do. But stay connected with peers, with colleagues, collaboration, supervision, case consultation, things like this, what you and I are doing right now, helps expand our field, helps connect our field, really. And I'm not just doing private practice. And I would say about the theoretical piece is, man, slow down. Therapy is slow, and it's a slow process because slow process leads to greater change.
mm,
I think sometimes either students, either therapists, we're so eager about let's get going, let's do these interventions, let's create change, and like our clients aren't even there yet. We
yes.
haven't quite understood kind of what they're after, and it may not even be safe.
Yeah.
And so slow down. Be in the, we challenge our clients to say, be in the here and now, be present when sometimes we don't do that ourselves. We're like, okay, what do I do next? What do I do next? How do I create change? And we're like, whoa, we just missed a critical moment
Mm,
right now in session with our clients.
mm. Wow. Slow down, stay in community as MFTs. Really wise words. Dr. Alex Hsieh, thank you so much for being here.
Mhm. Thank you so much, Dr. Amsaway. It's a pleasure being able to speak with you.
Lovely. Thank you so much for your time. And for the students that will be viewing this or any MFTs that will be viewing this, I'm very sure they will learn a lot from you and looking forward to continuing connecting with you. Thank you. Bye bye.